डॉक्टर ऋचा, डॉक्टर रश्मि,
हेलो।
हाँ डॉक्टर ऋचा, एम आई ऑडिबल टू यू?
यस, यू आर ऑडिबल डॉक्टर दिनेश। हेलो, हाय।
हेलो हेलो। अच्छा, मैंने रिकॉर्डिंग पे डाल दिया है, यूट्यूब से कनेक्ट कर दिया है।
हाँ हाँ, वो आ गया मेरे को यहाँ पे।
इट इज गोइंग ऑन यूट्यूब आल्सो लाइव।
या दैट दिस इज शोइंग इन द रिकॉर्डिंग, इट वाज शोइंग।
So Standy is looking good.
थैंक यू। बट सी यू।
डॉक्टर रश्मि ने भी ज्वाइन तो कर लिया है, आई थिंक उन्होंने ज्वाइन करके छोड़ दिया है।
हेलो डॉक्टर रश्मि। हाँ जी सर।
अभी मैंने कहा पहले ज्वाइन करा लेते हैं 2:15 से,
सर बिल्कुल ठीक किया।
तो दैट कि अब डॉक्टर भंडारी ज्वाइन करेंगे तो पहले उन्हीं को हम को होस्ट बनाएंगे ना।
हाँ जी।
डॉक्टर रश्मि चले गए हैं। मुझे तो डॉक्टर भंडारी का है कि पता नहीं वो भूल ना गए हो।
नहीं भूले नहीं होंगे, डालो उनको ग्रुप, उनको डाल दो।
हाँ,
अरे भूले क्या नहीं, डाल देते, भूल नहीं सकते। और किसी ने किया अभी पार्टिसिपेंट्स में? अभी तो नहीं किया होगा। डॉक्टर आलोक को डाल तो दिया मैंने। हेलो सर, गुड आफ्टरनून।
गुड आफ्टरनून।
हेलो सर, गुड आफ्टरनून सर।
गुड आफ्टरनून।
गुड आफ्टरनून। हम 4 ही लोग हैं।
हाँ,
प्रेसिडेंट साहब
अभी नहीं ज्वाइन किए।
पहला तो उनका ही है ना, सर का ही है।
हाँ हाँ। और कैसे हो सर?
मैं ठीक। आज आप कैसे बिजी हो, घर में कैसे प्लेस्ड हो?
संडे घर पे
घर पे ही हो ना?
100%।
वेट घटाए जा रहे हो, बड़ा स्मार्ट बनते जा रहे हो।
नहीं नहीं।
सर गुड आफ्टरनून सर।
गुड आफ्टरनून।
कैसे हो?
बस सर बढ़िया।
अच्छा, कितना?
आपका वोट तो नहीं होता उसमें, डीएम
नहीं
में?
सर, मैं स्टेट एग्जीक्यूटिव नहीं हूँ ना, तो स्टेट एग्जीक्यूटिव का बोर्ड होता है खाली।
हाँ वो पता है मुझे, इसीलिए रिकन्फर्म कर रहा हूँ।
हाँ नहीं, मैं हूँ नहीं स्टेट एग्जीक्यूटिव। बहुत जगह कुछ प्रेसिडेंट और सेक्रेटरी स्टेट एग्जीक्यूटिव भी बने हुए हैं, 2-2 पोस्ट 3-3 पोस्ट ली हुई हैं।
हाँ वो ठीक है,
तो स्टेट भी है, सेंट्रल काउंसिल भी है, वो कई जगह लोग जाते हैं।
हाँ, सब चीजों के फायदे उठा लेते हैं ना।
हाँ तो ठीक है।
ठीक है, इसमें क्या है।
हाँ
वो भी तो हमारे तो एक्चुअली मेंबर्स भी कम है ना, तो फिर
हाँ जी, हाँ
सबको पोस्ट देनी है तो फिर आपको मल्टीपल लोगों को इन्वॉल्व करना पड़ेगा।
हाँ जी, हाँ। ये है। अब मेन बात ये है कि लोग ज्वाइन कर लें, थोड़े से लोग, थोड़ा क्राउड होना चाहिए।
हाँ, आपने नाम तो अच्छे अच्छे रखे हुए सबके।
दिनेश ये जूम प्लेटफॉर्म कितने मिनट का है आपके पास?
ये तो
Extend
चलता
करना
रहेगा सर, टिल
अच्छा
मीटिंग
चल
लास्ट।
अच्छा अच्छा ओके ओके
टिल वेलकम डॉक्टर विनीत सर। इसमें सर ने ऑप्शन डाल दिया। वेलकम डॉक्टर विनीत सर।
हाँ जी, थैंक यू जी, थैंक यू। मैं कहा यार अटेंडेंस लगा दूं, इससे पहले तो निकाल दे हमको
नहीं
बाहर।
नहीं नहीं सर, सो नाइस ऑफ यू सर।
बड़े कातिल मूड में है भैया। मैं
कौन दिनेश?
कातिल मोड में बड़ी बात नहीं है। आई एम फीलिंग वेरी वेरी एम्ब्रेस समटाइम बिकॉज आफ्टर अ लॉट ऑफ एफर्ट्स द अटेंडेंस इज वेरी वेरी पुअर।
चले यार, एक्चुअली क्या है, लोग पहले तो ऑनलाइन भी ना नॉवेल्टी थी तो सारे ज्वाइन कर लेते थे। अब ऑनलाइन करते करते भी ना
ऑनलाइन तो थक गए लोग।
लोग तंग आ गए हैं। और वो दिन की 2-3 होती हैं। अभी देख, मैं बताता हूँ, अभी पहले मीट जॉनसन की अभी सुबह थी
हाँ जी
12 से
12:30
1-1:30 बजे। फिर अभी 2 से 4 ये है, 4 से 6 एक इनकी एबर्ट वालों की है। वो यार आदमी कहता है कितना यार बैठोगे, तो वही होता है।
एब्सोल्युटली राइट।
हम्म,
बट मेरा मानना
चलो
ये है
कोई
कि
नहीं।
ऐसी जो ब्रांच एक्टिविटी है उनको प्रेफरेंस दी जाए,
नहीं, वो तो बिल्कुल है ही, वो तो कहने की कोई
ज्यादा
बात ही नहीं है।
कंपनियों को पीछे रखा जाए।
गुड आफ्टरनून सर, डॉक्टर एनपी सिंह सर, गुड आफ्टरनून।
वेलकम डॉक्टर एनपी सिंह सर।
गुड आफ्टरनून, गुड आफ्टरनून। सॉरी,
कैसे
मैं
हो?
पूरी तरह से एकदम बिल्कुल डैमेज, 1 हफ्ता 10 दिन से था मैं।
क्यों, क्या हो गया सर, डैमेज कैसे हो गए?
वेरी
अरे
सॉरी।
अन्ना कोई बात नहीं डॉक्टर साहब। एक्चुअली मेरी मदर इन लॉ डायबिटिक और वो है ना, लास्ट टाइम कोविड हुआ था उनको, तो इस
ओके
टाइम भी हाँ, हम जब हम लोग को हुआ था सबको हो गया था। तो फिर मेरे ब्रदर इन लॉ की पोस्टिंग हो गई पटना, दिल्ली छोड़ के गए सारे को। अब वहां जाके वो सिक हो गई। फिर उनको पूरा एकदम डायबिटिक फ्लेयर अप, पूरा लंग्स खराब। वहीं पर आईजीएमएस से वहां रखे। अब तो खैर रिकवर कर गई है, कल रात हम आए हैं वापस, बट वेरी बैड। बीच में 2 दिन के लिए दिल्ली भी आए थे। अब हॉस्पिटल वाला बात भी है, समझते हो ना, बीच में छुट्टी देने के लिए। बट देख तो रहे थे यहाँ से, मतलब उस समय नहीं था कुछ वीडियो ऑन करते या कुछ करते इस टाइप का। इसलिए कल रात आए हैं कोई छोड़ के बाद। अब वही है, 4-5 दिन का क्वारंटाइन वाला सेल्फ बोला है यहाँ का, वाइफ वगैरह क्या आप रहिए, सब ऑनलाइन करिए सब कुछ। हॉस्पिटल वाले को भी बोला है हमने, आज राउंड के लिए गए थे वैसे। बोला कि सर रिस्क मत लीजिए, डिपार्टमेंट में एनआईसीयू में पता चलेगा किसी को तो फिर वो ऑब्जेक्शन करेगा। तो
हाँ वो
4-5
तो
दिन
खैर
तो घर
किसी
पर।
को पता
हाँ, क्योंकि किसी को हो गया ना बच्चे को गलती से भी, तो ब्लेम कर देगा डॉक्टर पे, ये चक्कर है, तो कुछ नहीं।
नहीं। आई थिंक डॉक्टर भंडारी आ जाएं तो।
हाँ, तो आपका एक्चुअली पर शेड्यूल में 2:30 से ही है उनका।
हाँ यस यस आई नो इट्स
हमने
फ्रॉम
अभी पढ़ा
2:30
मैंने 2:30
और
2:45
डॉक्टर
तक है।
भंडारी साहब वहाँ
वो
डीएमए इलेक्शन में।
तो
ओ, आज
2:29
इलेक्शन
से
भी है
पहले
ना।
तो नहीं आएंगे। 2:29 से पहले ज्वाइन नहीं करेंगे वो। नहीं तो उनको एक बार मैसेज डाल दो या मैं डाल देता हूँ।
आप डाल दो
सर
मोर इफेक्टिव।
मैंने सर अभी
उनको फोन कर देते हैं,
आलोक को
मैसेज
कॉल
तो
किया,
कई
सब
बार नहीं
उठा
पढ़े
नहीं
जाते।
थे। और एक मैसेज मैंने भी डाला था, बट अभी उन्होंने देखा
फोन
हाँ
कर देता हूँ,
फोन कर दो सर, फोन कर दो।
बिजी।
फोन कर देता हूँ।
मैंने डॉक्टर विपुल से लिंक बनवाया था ये। उन्होंने लगता है कि सबको एडमिट करने का ऑप्शन डाला हुआ है कि एडमिट करना पड़ता है।
कर दो।
नहीं अब ऑटोमेटिकली हो रहे हैं सर,
नहीं
ऐसा तो
मैं
नहीं।
कर रहा हूँ सर, यहाँ से ऑटोमेटिक नहीं हो रहे हैं।
अच्छा अच्छा कर रहे हो आप?
यहाँ पे ऑप्शन आती है एडमिट एडमिट करके ना, फिर आप करना पड़ता है।
ओके ओके ओके। यूट्यूब पे भी जा रहा है लाइव?
हाँ वो मैंने कनेक्ट कर दिया है यूट्यूब पे भी और रिकॉर्डिंग पे भी डाल दिया है।
ठीक ठीक ठीक।
व्हाट्सएप तो उठा नहीं रहे, फोन कर रहे हैं।
उपेंद्र को कर दिया था दिनेश फोन?
हाँ जी सर, मैंने उनको किया था तो पहले उन्होंने नहीं उठाया था, ही वॉज बिजी। फिर उनका मुझे फोन आ गया था 2 घंटे बाद,
हाँ,
तो ही सेड कि आई डेफिनेटली विल ज्वाइन, इट्स अ टाइट शेड्यूल बट आई विल डेफिनेटली ज्वाइन।
हाँ, क्योंकि 2:30 तक उसका कहीं और भी है।
हाँ हाँ, यस 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 यस। डॉक्टर नीलम से भी बात हो गई थी मेरी।
हाँ हाँ, ठीक है।
हाँ, मैम से भी बात हो गई थी, तो और ईमेल भी किए हैं सभी को।
ठीक ठीक ठीक।
वो
मैं ये कह रहा था सर, आप अपने यहाँ नर्सिंग स्टाफ यदि कोई ज्वाइन करना चाहे उसको भी ज्वाइन करा दो।
अच्छा, अभी तो आज थोड़ा
देखो यदि पॉसिबल होता है, एक बार फोन घुमा दो।
स्केलेटन स्टाफ ही होता ना आजकल संडे को।
हाँ,
देखता हूँ,
एक
डॉक्टर
कोई
ज्वाइन
मैसेज
कर
डाल दो, ग्रुप
लें,
है तो।
डॉक्टर ज्वाइन कर लें दोनों तो हो जाएगा।
हाँ, डॉक्टर ज्वाइन कर लें।
ललित को इनवाइट किया है? ललित को,
हाँ जी
डॉक्टर ललित को इनवाइट
सर,
किया
वो
है?
आज टीओटी है सेंट्रल आईएपी की, मेरी कल बात हो गई थी उनसे।
वो
अच्छा अच्छा
पुलमेन
अच्छा।
में
एक सेंट्रल आईएपी के ना डेवलपमेंटल डिसऑर्डर्स पे टीओटी है,
हाँ, ये
होटल
पुलमैन में।
पुलमैन में, तो ही इज
पुलमैन
बिजी
में,
देयर।
ओके ओके।
तो मैंने कल उनको बोला था, कहते यार मुझे लेके जा रहे थे, तो मैंने कहा यार मेरा तो अपना ही ब्रांच का प्रोग्राम है। मैं कहाँ जाऊंगा। कह रहे अच्छा। वेलकम डॉक्टर रश्मि मैम।
रश्मि, ऋचा दोनों म्यूट है। ऋचा, पीछे क्या लगा रखा है? बैनर कौन सा है?
बैनर सर हमारा हैप्पी बर्थडे डेली का।
अच्छा अच्छा।
बैनर
ये अभी पूरा हफ्ते चलेगा हमारा।
हाँ, गुड गुड।
हाँ,
विजिबल
वो उसमें ज्वाइन कर लो, बस हमारे को लोग चाहिए, आप भी ज्वाइन कर लो। हाँ, सभी ज्वाइन। हेलो हेलो हेलो। हाँ डॉक्टर लवराज, अगर फ्री होंगे तो ये जूम का लिंक भेजा है, इसमें आप ज्वाइन कर लेना। हाँ, जो भी ज्वाइन कर सकते हैं ज्वाइन करें।
डॉक्टर भंडारी से बात हुई सर?
तो भंडारी का
नहीं, उन्होंने दोनों फोन नहीं उठाए।
अरे सर अभी फोन आया उनका, उनसे मैंने बोल दिया ज्वाइन करने के लिए।
चलो फिर
मेरे
ठीक
साथ
है।
डीएमए
डॉक्टर भंडारी और डॉक्टर प्रशांत सेठ का है ना पहला दो, फर्स्ट 2।
डीएमए में थे, मैं अभी डीएमए में हूँ, तो मैंने उनको बोला सर आपका ही फर्स्ट है, आप ज्वाइन कर लो, तो कह रहे हैं ठीक है।
आगे डॉक्टर भंडारी सर आगे। वेलकम सर, प्रेसिडेंट सर। सर नमस्कार सर।
ऑडियो कनेक्ट हो
डॉक्टर
रहा
भंडारी
हाँ
सर
जी,
नमस्कार।
ऑडियो कनेक्ट हो रहा है भंडारी का। गुड आफ्टरनून डॉक्टर भंडारी।
गुड आफ्टरनून सर, गुड आफ्टरनून।
सर वहाँ मौके पे क्या रिपोर्ट है आपकी?
बिल्कुल ठीक है सर, बस हमारे सेक्रेटरी सर से हमें शिकायत है, अगर मीटिंग ऑफिशियल है अभी अनऑफिशियल है?
अभी तो अनऑफिशियल है, बताइए सर।
अनऑफिशियल में ये है कि 180 लोगों ने मुबारक दे दी, बेस्ट विशेस दे दी, तो हमारा सेक्रेटरी दूसरे पैनल के कैंपेन करी जा रहा है और इसलिए तौहीन समझ रहा है कि बेंचो बेस्ट विशेस भी कहते हैं, बेंचो तो ऑपोजिट कैंडिडेट ने भी दे दी बेस्ट विशेस।
हमारे लिए तो सबके लिए ऑल द बेस्ट है सर। वन
तो
वे
भेजा तो नहीं,
विपुल को पहले ही कह दिया था।
विपुल को ही कहा, बाकी किसी को नहीं कहा, भेजा तक नहीं।
मैंने उनको कहा सबके लिए ऑल द बेस्ट है।
ना प्रशांत को बोला, ना तो प्रेसिडेंट को बोला।
वो चाहते हैं कि आप एक दिमाग लगा के खाली इधर ही आईएपी वेस्ट का सोचो,
उधर मत जाओ,
फाइनेंस छोड़ दो,
उधर मत जाओ।
उधर मत
आपको
जाओ।
पता है सर, हमारे पास
हमेशा ना आईएपी में डीएमए जरूर घूमता है।
इतने ग्रे सेल्स हैं कि हम 2-4 संस्थाएं तो देख ही सकते हैं।
अरे वाह,
अब तो ऑलरेडी 4 के तो मालिक हो, 5वें के चक्कर में मत पड़ो ना।
नहीं, कुछ नहीं ऐसा, वही वाले ही देख रहे हैं। आप पहुंच गए हो, घर पहुंच गए हो उत्तम जी? हैं?
आई एम बैक होम।
तो वो पाठक सर नहीं आया, जेसी पाठक नहीं आया वोट डालने?
पाठक एक्चुअली क्या बिजी है, उसका परसों वो नाना बना है।
अच्छा,
तो उसको बोल रिक्वेस्ट तो की है, देखो पहुंचता है कि नहीं।
अच्छा।
बाकी मेरे को उसने श्योर करके भेज दिया था, जो मैसेज भेजा श्योर भी लिख दिया और हाथ भी जोड़ दिए।
चलो ठीक है,
पहुंच जाएगा।
हाँ हाँ
सर स्टार्ट कराएंगे, 2:32 हो गए।
हाँ 2:32 सर, बोलो आप स्टार्ट कर दो।
ये देख लो, एक और बंदा उत्तम, ये अर्नेजा जी भी कुछ कह रहे हैं। उत्तम जी,
अर्नेजा क्या कह रहे हैं? हाँ भाई, बेस्ट ऑफ लक।
तू कहाँ से बोल रहा है? यूएसए से बोल रहा है, इंडिया से बोल रहा है?
यही हूँ घर पे।
हमारी तरफ से सबको ऑल द बेस्ट।
चलो, थैंक यू वेरी मच।
देखिए विपुल भी आ गया, हमारा एक और ईवी।
थैंक यू वेरी मच।
विपुल बेस्ट ऑफ लक।
ये तो डीएमए के प्रेसिडेंट रूम में पहले से ही बैठे हैं सर।
ये डीएमए साली नहीं की है, और किसकी है? अब जलेबी नहीं आई आपकी? जलेबी से आ गए? अच्छा ये आ गए।
हमारे सेक्रेटरी भी देख लो।
सर ऑल द बेस्ट सर, सबको
ऑल द बेस्ट।
थैंक यू।
कैसी चल रही है सर वोटिंग?
वोटिंग भैया, आईएपी वाले खड़े हैं, आईएपी वाले बात कर रहे हैं।
सारे डीएमए पे आईएपी का कब्जा हो रहा है।
ओनर एक अलग आ गया,
प्रशांत भी आ गया।
कराओ सर, टीसीएच कराओ। ये भी बैटरी प्रैक्टिस स्टार्ट करेंगे, आईएपी ज्वाइन करेंगे।
डीएमए पूरा जब पीरियडिशन का होल्ड हो गया है।
डीएमए में भी यही होने वाला है।
पीडियाट्रिशियन के पास काम धाम तो नहीं रहा, चलो पॉलिटिक्स ही कर ले। और
को प्रेसिडेंट बनाना है आप।
सर डॉक्टर भंडारी सर,
आपको खड़ा करना है।
स्टार्ट करो सर।
इसी साल
मैं बोल देता हूं सर पहले। Good afternoon everyone, and it's my proud and privilege to start this breastfeeding week. It's a very prestigious event for the IAP and whole world. And on 7th August we celebrate the breastfeeding day. And today we are starting this breastfeeding week at our branch. And I am very delighted to have you dignitaries on this platform. And may I now invite Dr. Alok Bhandari, the president of our branch, IAP West Delhi City branch, to give a welcome address, and then we will proceed for the next sections. Please, Dr. Bhandari, sir.
Am I audible, please?
Yes, yes.
Good afternoon, friends. Very warm welcome on this August day of 1st August and inauguration of breastfeeding week. As you know, breastfeeding is an issue which is very close to the heart of all pediatricians, and we are always striving that success of breastfeeding leads to more and more reduction in the morbidity and mortality in the neonatal and pediatric age group. And it is very important to stress the importance of breastfeeding. And what a better way that CIAP has taken its initiative to organize it as at a big level And I'm happy to share with you that IAP West Delhi is not lagging behind any of the major branches, though we are a city branch, local branch of a Delhi state branch. But our performance, our activities, our actions during the breastfeeding week will not be less than any of the major branches. I'm very thankful to have a hardworking team of and full cooperation from our President-elect, Dr. Devendra Gaba sir. Dr. Dinesh Goyal is our dynamic secretary, working very hard for all the activities. And Richa Parashar is our new blood, new energy in the team as joint secretary. And our all seniors, Dr. Uttam Pal, Dr. Sangeeta from Guru Gobind Singh, Rashmi Gandhi from this Acharya Bhikshu Hospital, Dr. Nipdaman and Ritu Chawla, Anil Gulati from Deepyal Hospital, and everybody is involved whole soul in this program. And I'm sure we'll give a very good interactive program with detailed activities have been planned throughout the week, where we will be promoting and ensuring that breastfeeding is very much promoted and the desired results are achieved. I again welcome you all and hand over the mic to Dinesh for further proceedings. Thank you, please. Thank you.
Thank you, sir. Thank you so much for your kind words. And it is wonderful to have you on this platform. And now, may I invite Dr. Prashant Zet? Has he joined, sir? Dr. Prashant Zet?
He was there. Ask Dr. Bhandari.
He will introduce the speakers. Today we have very eminent speakers for this.
Prashant? Yes. तूने ज्वाइन नहीं किया हुआ इस पे कर लेना Prashant is here. He had some network issue, I think.
Yes, sir, he can take
he will take my phone and
yes, sir. Yes.
Hello.
Very good afternoon, Dr. Prashant, sir.
Good afternoon. So
may
I
I
would definitely
please
like
introduce the
to,
speakers.
Yeah. So first of all, the talk is by Dr. Devendra Gaba. He is a senior consultant pediatrician and having Genesis Hospital, and he has been the executive member of IAP Central IAP Board, and at present he is the president-elect in IAP West Delhi, and he is very active member, very dynamic, and always supporting all our programs. Last week he supported ORS. We held an activity at Genesis Hospital, and we are really proud to have Dr. Devendra Gaba with us. And after that, the talk is by Dr. Neelam Mohan. She is, as everyone knows, she is a very renowned pediatric gastroenterologist and hepatologist at Medanta Hospital. And she is a part of IAP West Delhi group also. And we are really privileged to have her there as a guest speaker. Then Dr. Upendra, he is from Bombay, and he is a great authority on breastfeeding. And the way he has worked, the whole nation is proud of him. And after that, our own Dr. Richa Parashar, she is the finance secretary of IAP West Delhi. She will be giving the last talk. And I would definitely like to welcome all the guests and our distinguished faculty to launch this breastfeeding week celebrations by IAP West Delhi. We'll be having all the week activities. We'll be having some public lectures. We'll be having some community activities also. And we are planning a skit in a government hospital, Acharya Bhikshu, for the general public to encourage them about breastfeeding. So now with all this introduction, I would like to call Dr. Devendra Gaba to deliver his first talk. Dr. Devendra Gaba, please.
Thank you, Dr. Prashant. And I thank Alok Bhandari, President Sir, and Dinesh Goyal, Richa Prashar, Dr. Uttam Pal, Vineet Sehgal, and Dr. Vipul Jain. So I start my talk. Today, I am going to talk about breastfeeding basics. As you know, if we want to support, protect, and promote breastfeeding, we have to answer all the questions raised by the mother to be and their relatives. So that way we have to know each and every aspect of breastfeeding and anatomy and physiology of the breast and lactation. I go to the next. About nutrition education program updated. This is a very excellent program of nutrition in children. I thank Dr. Elizabeth. She is scientific chairperson, national coordinator Dr. Neelam Mohan, and scientific convener Dr. Upendra, in addition to the whole team, president and secretary. Then about the 1,000-day window of opportunity. This is basically a period of maximum developmental plasticity, therefore has greatest potential to affect health and well-being over the life course. And adverse environmental condition in this period affect at least 3 generations. Period when brain, gut, and microbiome, especially microbiome, are in constant close communication and work as a single integrated system. Now, this optimal breastfeeding in first year coupled with appropriate complementary feed alone can reduce the under 5 mortality by 1/5. It is amazing. So it is shared responsibility of all of us, pediatricians, obstetricians, staff nurses, mothers, and each one influencing the new mom to protect breastfeeding. So the apt logo and theme of this year is Protect Breastfeeding, a Shared Responsibility. Now about lactation, we come to lactation. It is the process of milk secretion, as you know. Rate of milk secretion is directly correlated with the frequency of milk removal. Now, how lactation mechanism works. As you know, milk synthesis is in 3 stages. First, 20 weeks, it is the initiation of synthetic capacity of mammary glands. The influence of progesterone and estrogen around 16 to 22 weeks. The second is lactogenesis 2. This is immediately after the birth on the day 3 to 5 postpartum. The onset of copious milk production. This is basically when progesterone and estrogen, they fall and prolactin increases. And the third stage is lactogenesis 3. It is the maintenance of mature milk. It is basically a local condition. This letdown reflex comes. This is basically when baby sucks from the nipple. The afferents, they go to hypothalamus. Hypothalamus sends on and off. Dinesh, can you mute everyone? Dr. Dinesh? Hello? Hello?
I think this meeting is hacked by someone.
Vipul? Yeah. Then afferents goes to a hypothalamus, and hypothalamus has got 2 switches, on switch and off switch. On switch stimulates the oxytocin neuron, and off switch inhibits, it makes it prolactin inhibitory cell is inhibited. So prolactin is produced and lactogenesis starts. And on the other side, oxytocin is also released. It causes contraction of the cells, myoepithelial cells of the gland, and milk is excreted out. Now, this National Family Health Survey data 15-16, it shows early initiation of breastfeeding percentage was 41% within first hour, and exclusive breastfeeding 0 to 6 months was 54% only, and introduction of appropriate complementary foods at 6 months was 42%. Now about lactation failure, it is defined as low milk output in the mother, inadequate to meet the baby's requirement, and the causes are delayed lactogenesis 2 and failed lactogenesis. And delayed is usually interval is longer than usual, and but the mother has the ability to achieve full lactation in this case. So we have to work on this basically. And failed lactogenesis, there are two types. Primary is inability to produce adequate milk. Secondary is improper breastfeeding management and or infant's problem. Now, what is the estimated rate of failed lactogenesis? It is 5% only. And delayed lactogenesis is 15%. Given early opportunity to breastfeed, breastfeeding assistance and instructions, the vast majority of mothers and babies will successful in breastfeeding. Lactation insufficiency can be true or perceived, mostly perceived. Mother asks, am I producing sufficient milk for my baby? It is a common concern of every mother. Now you can explain by giving this example. On day 1, you need only 5 to 7 ml per feed, because stomach size is 5 to 7 ml. And on day 3, it is 20 to 25 ml, a walnut size. And at 1 week, it is like an apricot, 45 to 60 ml. And at 1 month, it is only size of a large egg, that is 80 to 100 ml. Now, risk factors for delayed lactogenesis, usually these are the risk population where we have to work, like primipara, psychosocial stress or pain, maternal obesity, diabetes, hypertension, stressful labor and delivery, cesarean section, delayed first breastfeed episode, low perinatal breastfeeding frequency or elevated cortisol. Now, the causes of failed lactogenesis primary, they are basically breast tissue is reduced, glands are reduced, and have a low milk supply. It is seen mostly in breast surgery or injury, retained placental fragments, cigarette smoking, hypothyroidism, hypopituitarism, ovarian theca lutein cyst, mammary glandular tissue, polycystic ovarian syndrome. And secondary failed lactogenesis, usually it is due to stress to mother and fetus during labor and delivery. Smaller infant size at birth, large infant size at birth in primipara, absent or insufficient or dysfunctional suckling, and incorrect latch, the most important one. Overuse of pacifiers and artificial teats. Now, what are the signs of ineffective breastfeeding or delayed lactogenesis? This is, you will find by initial infant weight loss, which should not be more than 10% on day 5. And less than 6 wet diapers per day after day 4. We can remember like that, 1 diaper per day on day 1, 2 diaper on day 2, 3 diaper on day 3, 4 diaper on day 4, and 6 diapers beyond that. delayed bowel movements and continued meconium stool on day 5. No audible swallowing from baby or poor transfer of milk. Signs of dehydration, poor skin turgor, weight loss more than 10% or high sodium. Infant is irritable, restless, and lethargic. Minimum or no breast changes by day 5 after delivery. Then persistent or increasingly painful nipples, intolerable pain in the breast, unrelieved by intervention. Early management includes initiate breastfeeding within 1 hour of birth. It helps in earlier effective suckling and feeding behaviors, enhanced maternal-infant bonding, improved neonatal temperature control, longer duration of breastfeeding. Second is identify and eliminate causative factors like local breast or nipple problem, identify improper attachment and wrong feeding practices, reinforce mothers, build their confidence and ensure frequent and efficient suckling. Now, how can you make breast stimulation, maximum breast stimulation? This is basically a demand and supply principle. You have to breastfeed 8 to 10 times or more in 24 hours. Breastfeed at night especially. No restriction on length of breastfeeds. No restriction on frequency of breastfeeds. More suckling, more milk. Promote emptying of breast by expressing breast milk either manually or by breast pump. Expressing mother's own milk, this will be covered by Dr. Richa. Now, galactagogue should never replace evaluation and counseling. This is the most important point. We should not blindly give galactagose. First, you talk to the mother and evaluate and counsel her. Water is the best galactagogue. Then other natural ones, they are not scientifically proven, but might have a placebo effect, like shatavari and all. Then the medicines wise, there are two, domperidone and metoclopramide. Domperidone is preferred because it is listed L1 and safest, and the dose is 10 milligram 4 times in a day. Can be used long term also. Now, correct choice of supplementation. Determining the need for supplementation is essential in promoting growth and energy levels. Short-term supplementation may be considered till a significant improvement in lactation is seen. Basically, it should be short-term only. Ideally, expressed breast milk or formula be given as complement immediately following the breastfeeding episode rather than supplement. This is from best to worst. Mother's own breast milk, fresh, donated fresh preterm milk, donated fresh term mature milk, then pasteurized donated breast milk, then preterm formula and ordinary formula. Renal solute in different milks is like that. Breast milk is 93 and cow milk is highest 308. And upper limit permitted is usually 275. Higher renal solute load, excessive protein load in cow milk can also overload a baby's kidney. Now, human milk has no comparison. Formula or animal milk, they cannot compete with human milk, which is the best and the wonder liquid for an infant. It is free of bacterial contaminants and has got anti-infective factors and growth factors present. Protein is in correct amount and easy to digest. Fat is enough essential fatty acids and lipase to digest. Iron is in a small amount, but it is well absorbed. 49% of iron is absorbed and enough vitamins and water. Then cow milk has got other health risks also like CMP, cow milk protein allergy, and type 1 diabetes mellitus. Early exposure to cow milk protein may be an additional important factor in initiation of beta cell destructive process. Early exposure to CMP increases the risk of developing allergy. Dilution of cow milk does not rectify nutrient composition to suit the needs of infant and can also increase the risk of contamination and thus infection. Iron content, as I told you, is low in both human and bovine milk, and absorption in from human milk is much better. It is 49% compared to bovine milk, which is just 4%. Iron absorption is due to good facilitators are high lactose and vitamin C, and loss of iron is almost none. So promote exclusive breastfeeding. Promote iron-rich complementary foods after 6 months. Cow milk and other nutrients. Cow milk does not provide enough vitamin E, iron, linoleic acid, and essential fatty acid. It has a high content of protein, sodium, and potassium, very high ash content. So kidney load is much more. And in human milk, good protein like lactalbumin is 60 and casein is 40. Then what is the method of choice to feed the baby if you want to give supplementary feeds? A supplemental nursing device at breast, cup feeding or spoon or pellet. Cup feeding is recommended choice as it has been shown to be safe for both term and preterm infants. It helps to preserve breastfeeding duration and reduce nipple confusion in babies. Bottle feeding is not recommended. Now, WHO 2018 position paper says immediate and uninterrupted skin-to-skin contact and initiation of breastfeeding within the first hour after birth are important for establishment of breastfeeding and for neonatal and child survival and development. The protective benefit of early initiation extends until the age of 6 months. The risk of dying in the first few days of life is 33% higher for newborns who initiated breastfeeding 2 to 3 hours after birth, as compared to those who has taken milk feed before 1 hour, and more than twice for those initiated a day longer after birth compared to newborns who were put to breast within first hours of birth. So we can reduce the neonatal mortality by half if we initiate breastfeeding within first hour of life. These are the baby-friendly hospital initiatives. There are 10 steps to successful breastfeeding, and WHO has revised in 2018 guidance to protect, promote, and support breastfeeding. These steps are hospital policies, staff competency, antenatal care, care right after birth, support to mother, supplementing if medically indicated only, rooming in, responsive feeding, no bottles, teats, or pacifiers, and discharge policy. Hospital policies, it should be a written infant feeding policy, not promoting infant formula, bottles, or teats, making breastfeeding care and the standard, making breastfeeding care the standard practice, keeping track of support for breastfeeding, data management and monitoring. And staff competency, training staff on supporting mothers to breastfeed, assessing health workers' knowledge and skills, and explain them anatomy of breast, physiology of breastfeeding, recording the first feed in every baby, ensuring first gift to every baby. Then antenatal care, discussing the importance of breastfeeding, health talk, display of posters, distribution of books or pamphlets, discussion with pregnant women and family members. Very important. Obtain detailed history of breastfeeding in previous children, nutritional and diet counseling, and how to ensure antenatal class attendance. This question will be answered by Dr. Neela Mohan. Then supplementary feed, hello, supporting mother, checking position and attachment and suckling, giving practical breastfeeding support, helping mothers correct latch with common breastfeeding problems. Supplementing, giving only breast milk unless there are medical reasons. Prioritizing donor human milk when a supplement is needed. Rooming in is very advantageous to the baby. It decreases stress, allows breastfeed when hungry. It is safe. And in case of mothers, learn and feel feeding cues in the baby, better quality sleep. Then responsive feeding. This is basically helping mothers know when their baby is hungry, not limiting breastfeeding times, understand hunger cues. In this, we have early cues, mid cues, and feed me at third stage. Basically, these will be discussed in detail by Dr. Richa. Then say no to bottles, teats, and pacifiers. Counsel mothers on the use and risk of these bottles, teats, and pacifiers. Then discharge policy, referring mothers to community resources for breastfeed support, working with communities to improve breastfeeding support services. Then to summarize, true lactation failure is rare. Delayed lactogenesis can lead to failed lactogenesis if measures to correct them not taken in time. Secondary lactation failure can be prevented to a large extent by early initiation and teaching mothers the correct feeding techniques and encouraging her to feed frequently. Even after delayed lactogenesis or secondary failed lactogenesis, milk supply can be successfully re-established by guiding mothers correctly, explaining adequacy indicators, resolving breastfeeding related problems like nipple trauma, engorgement, etc. at the earliest, and motivating them to continue breastfeeding. Then counsel mother about balanced diet and instill confidence in the mother and the family rather than prescribe galactagogues or formula. As you know, milk is species specific and cow milk is not recommended before 1 year of age. It is more difficult to digest, has a high renal solute load, and can cause other health problems like iron deficiency, allergy, and diarrhea. In lactation failure, donor breast milk formula supplementation is a better and safer choice as compared to cow milk, provided correct preparation and ideal feeding technique is taught to the mother. Then a word about 8-gear model to promote breastfeeding. In this advocacy, then political will, legislation, and policies like maternal leave, workday breaks, or WHO code. Then baby-friendly hospital initiative and community help. Then funding and resources, training and delivery, then promotion of breastfeeding by again healthy baby initiative, then through media and breastfeed week as we are celebrating now, followed by research and evaluation. This all is by coordination, goals, and monitoring. Then I pass on to Dr. Neela Mohan for the next talk. Dr. Neela Mohan.
Welcome, ma'am.
Hello.
Good afternoon, ma'am. Very welcome. Ma'am.
Can you allow me screen sharing?
Yes, yes. Just 1 second, ma'am. Already started. 1 second, ma'am. Now you can share your screens, ma'am.
Okay. Yeah. So am I audible, please?
Yes, yes, ma'am.
Yes, ma'am.
Yeah. Firstly, I would want to congratulate everybody on this breastfeeding week. And I'm humbled with Dr. Devendra Gama giving this to me because he realized that every woman should know about breastfeeding. Every doctor, even an MBBS, everybody should know about breastfeeding. So irrespective of the specialty that he chose me, I want to touch my heart and say happy friendship, say I'm really humbled with the entire team because you realize that all of us, so while preparing for this lecture too, I was looking at the module which has come out for the IAP for the mothers and all. So it was quite a lovely journey, and I also participated in the EPIC module 1000 days because nutrition is very close to me, and you'll be surprised I actually worked on maternal nutrition. So I worked in that maternal nutrition, then I was working in parenting module. So thank you for teaching me breastfeeding. Some tips which I had forgotten, I had to revise, and because everybody asks you, irrespective of what specialty you are. So I have 15 minutes and I will be rushing through the slides because I know I'm talking to experts here and not the mothers. But at any time in the end, you all need, we can discuss that. So scenarios generally, like obviously a person, baby who's breastfeed, typical scenario when baby is born, mother is sleeping, cesarean, the grandmother comes and she wants to feed honey, and the nurse or the doctor is shocked what's happening. So there could be none better than me to speak on this, that trust me, you are damaging the entire gut flora by that one feed which you thought mother was tired, by that one honey which you gave. So it is so important to inform this to the attenders and maybe to the mother just before the delivery, that giving the feed which actually stimulate her oxytocin reflex and all that, and it is very important and she should not damage. So the granny should not be allowed to this, and because the granny thinks that how will she ensure a good latch, and that's how we are going to discuss about the latching. So this is something new which I was not talking about. It was nice to learn about it, that they have recent. Received on phone pay. Somebody is talking, okay, must be. So latch, LATCH, that they are talking about how the latches, audible swallowing, type of the nipple, the comfort, hold. I would go through each part, but very important is to put this chart in the delivery room and wherever babies and moms are there, because the caregiver should understand that anybody who has a score of less than 7, 2 into 5 was 10. So anybody who has less than 7 needs assistant, and that's how they need to be talked about it. So the latch score, and this is very important, which has been highlighted a lot in the breastfeeding weeks nowadays. How often to feed is what everybody asks this question, and generally we used to say earlier desired or demand feeding. That's the word we were taught. So what I want you all to know is not only demand feeding, because in the next slide I'll say cry is a late sign. You should even if the baby, especially in the early babies, will tend to get hypoglycemic. So the baby is not demanding for 2-3 hours. You can probably tickle and see how the baby is. But what we're trying to tell you is, don't wait for this last crying, agitation, turning red. That is not what we say demand feeding. एक कहावत है कि बिन रोए माँ भी बच्चे को दूध नहीं देती. So उस कहावत को serious sense में नहीं लेना है. What you need to teach them is to look for this early cues and the mid cues of steering, mouth opening, stretching, physical, hand to mouth. I think this is very important, because when I was a resident, I was never ever taught to tell this to the mothers till I actually, subsequently was a consultant in Gangaram, and so during the rounds learned about it. So it is very important to teach everybody about this response and not just wait for the baby to cry. And we used to also say is that maybe if a baby is cold, sluggish, lethargy, you must touch, see what the baby is not feeding, and then approach the baby and not wait 4 hours, 5 hours if the baby is sleeping, not that. So this, we all know that prolactin is so important for this. And next slide, I'm going to highlight how it gets inhibited and how it gets enhanced. We don't even think about it. This prelacteal feed, which you give off some other feed, is very important, because many mother was tired. Upar ka doodh ek hi diya, ek bottle di, bas ye kiya. We have to totally discourage. Of course, we've been talking about colostrum and all that, immunity, immunoglobulins, but we need to now explain them this, that this prolactin, this prelacteal feed is very important to enter into the production, which the granny asked me in the first question, how do I do it? So I have to tell this to the granny that all this dummy, pacifier, bottle, painful breast condition, etc., all this will inhibit and it gets enhanced by the baby. The more you suck, we used to tell, ab jitna pilaoge utna aur doodh niklega, so Beryl said. And jaise it's like the chicken the hen story. That's what we can say. Murgi se ande se murgi, chicken the hen story. Because if the baby starts and then it is more produced. So it's like both that you get, and this is more secreted at night. And every time you feed, it gets produced to manufacture for the next feed. So if you've not fed, so the manufacturing will not happen and empty the breast. Oxytocin reflex is very important. And this, I think, if I'm allowed to say, is what is called the maa ki mamta. This is not what, sadly, the father ki mamta can do. It is the maa ki mamta which will help to improve that stimulation, loving thought, sound, thought of the day, confidence, kangaroo mother care, all this. And of course, if you have a granny who's shouting around and saying, nahi nikal raha hai, kuch nahi ho raha. So this worry, stress, doubt, this will give rise to problem. And the separation, of course, the pain that she's undergoing through the cesarean section. So it is very important. Like when I had a baby, all that I was interested in knowing is darad to nahi hoga. So I took 10 years to have another baby because the pain never went out of my mind. And like so many of us have issues with the sacrum, dilatation, etc. So you should not think that सब बच्चों को सब mothers बच्चे पैदा करते तुझे क्या special extra दर्द हुआ. When I did my gynecology internship in Safdarjung, I trained in Osmania, but I did my internship in Safdarjung. And I used to be very upset because I saw mothers, they were not uniform. Some mother had more pain than the other. And you need to respect that. It is the Birbal saying to Akbar that फूल तो जंगल में भी होते हैं लेकिन उनको बिन पानी डाले भी फूल जाते हैं और घर के फूल को पानी डालते हैं. So it's all the way you're brought. You can't just say कि सब पैदा करते हैं तुझे नहीं होता. So using such harsh language to the mother is not needed. And oxytocin contracts the uterine muscle and helps preventing further pregnancy. And this is really important. As long as the mother is feeding the baby, she will get let down of the breast from one end. This. So second case is mother is got two twins. How do I do? So these are beautiful. I wish they had put in some pictures. It is not done, but we all know what is the cross cradle, the football position like that, and the cross cradle position. So teach them all that positions. And next time I'll request you all to please put the cartoons into this for us to explain these two positions that we are talking about. Retracted nipple. Now we need to understand that there is no need to diagnose or treat a nipple that looks inverted during pregnancy. There is this, all latest guidelines suggest you that people used to say earlier on that you work on your nipples before, in the pregnancy if you don't. But nowadays all that theory is discarded, that post-delivery automatically the nipples and all will be there and you don't need to work on them pre-pregnancy. And the cracked nipples, all of us that had cracked nipples, you need to teach the mother about the applying oil, little gentle massage, and the hind milk. What is the logic? Foremilk and the hind milk. Foremilk is lactose and the hind milk is fat. So the hind milk helps the baby to get satisfied. So it's a win-win situation. The hind milk, the baby will get satisfied. So we need to tell the mother, ki aadha idhar or aadha idhar nahi, because once she takes the fore, gets the lactose, then the hind gets the fat, so satiety will be there. So next time she starts from the other side. So allow a good latch to the areola. I'll talk about the areola feeding next. Look for the local candidiasis, etc. If there is candidiasis for the baby, you can give the, we've been talking about the candid mouth paint, clotrimazole, wash towels, and we need to tell them, the mothers, the bras, the towel, all this should be washed with hot water and dried, and she should not wear kacha and all that. We forget to talk all this to low class and middle class, and it is responsibility of all those who are hearing to notice just those 10 points out of the whole talk, only 4 or 5, which you know, but you forget to talk, and you should talk when you meet your mother. And of course, we don't give fluconazole to all mothers. We only give it when we think that applying a cream is not really useful and it's a deep aching breast pain with persistent thrush, then we give them. Otherwise, we suggest them cream, and the mother wants to know, does she clean rigorously before giving a feed? We need to tell them that they are quite baby savvy creams and no issues, because anyway we put drops in the mouth also, so there's nothing about it. So next comes on the breast is engorged. I don't know what is the two definition. Is it full or is it engorged? Very simple definition. Engorged has fever, full there is no fever. In full the milk is flowing, in engorged the milk is not flowing. So engorged is painful, edematous, red nipples, milk not flowing and fever. Here, milk flowing with no fever. And of course, it is hot, heavy and hard. And all mothers, I can vouch, all mothers have had full breast. There cannot be a single mother who says that she's not experienced it. You get so desperate that you just need to, if the baby is not around, you would want to just express it out. And this is what we are talking about, removal of milk. If the baby is not able to express milk for whatever reason, very important to talk about removal of the milk by self hand massage or a pump or a bottle. There are so many now, everywhere it is available in the market. But when we were young and students, things like this were very difficult to arrange. A breast pump used to be, having to send to Cannot Place now and go get it. So things have improved since then. And engorgement is because of plenty of unexpressed milk it will give rise to, and ultimately she's not able to take it out. So sometimes when you are dealing with children as pediatrician and the child is admitted with you in ICU, don't forget to talk to the mother. Who would have talked to the mother? The doctor did not tell the mother, and you were busy looking after the ICU. trust me, it is a protocol in my unit that whenever we have a baby who is, for whatever problem, is admitted under me, usually liver or more in the ICUs, we always talk to the mother a minute. I always insist to tell about talking about breastfeeding, about this. So the next message which you need to note down in today's presentation is not only about breastfeeding to a mother who comes to you about asking feeding, is when the baby is admitted with you, then also tell the mother what to do to prevent engorgement, because you were responsible for that by not telling her. So now breast abscess, I hope I'm not short of time. It's a 15-minute script lecture. We know if there is an abscess, you need to give antibiotics. You need to talk to your surgeon if you need drainage, and you need to feed from the opposite side. May stop due to the local effect. We know what this, but if no emptying, slowly milk from opposite side will stop. So this is the key message which you need to give to the mother. Nahi bhi pila rahe to karo, ek se pila rahe to bhi karo. This is what we need to see. Phil is the feedback inhibitor of lactation. So when that inhibitors get stimulated if you're not giving, and that is why sadly when you lose a child, it's not like the mother keeps giving it. Sometimes we give tablets also to dry the milk, and sometimes when the baby is too sick and all, the mother says it's already dried. So this does happen in there. And NICU baby not able to feed, teach how to express and give to the baby the EBM. And if your baby is not taking, please give it to the milk bank, because this is just like organ donation is one of the biggest donation in life. Next to that, what you can donate is also breast milk. Of course, Vidya, what we are donating is also a very big important factor in donations that you talk about. So we need to impress to her that how important, don't be selfish, donate this for someone. And the expressed breast milk, we've talked about the pump, we've talked about the and we also talk about the comfort with a hot bottle, and we talk about the shower, that you need to take a hot water shower or a hot water, because that will lead to milk and make them soft so the baby is able to take. And this is very important, choking. Sometimes the mother is very scared because she herself has seen this choking done. So I think it's not a bad idea to understand about this and talk to the mother when you think that there is a lot of fullness of breast, that a strong milk ejection frequency, the child sputters or chokes, and then the mother can either remove it and take out, slow down, or unlatch and express the flow. This commonly, it's a knee-jerk reaction. Like if I do, everybody will blink. This is what the mothers would do even if you don't teach. But you could also tell her that the position should be proper, the 3 positions that I was talking, and the module which talks about the mothers talks that even if you want a tired mother can give lying down and how it should be side. So this choking can be a very major issue in lying. So you need to ensure that the baby is facing towards you in that position. If not the typical position or the football position, they should be taking. And then the baby is refusing to suckle, then of course, instead of just saying, Rani tere dimag mein hai, Rani sab kuch theek hai, like how Safdarjung people would talk, I think you need to look into it. What else could be the reason? Though this is a small part, but nevertheless, it needs attention. Was there infection, what we say, pain from the bruise, blocked nose, oral thrush for the baby, hypoglycemia, difficulty, poor attachment, engorgement, coordination, sex reflex, not getting enough milk, bottle need. So there are so many things, routine, separation from all that. We only think of one thing, which not getting enough milk. That is not always the truth. You have seen, I've highlighted so many things. It is your responsibility to keep 2-3 charts in your breastfeed. One, I talked about the scoring. Anybody more than less than 7 needs help. Second is the conditions, the previous slide, which I said, what are the causes for breastfeed, so that your resident, your younger doctor, your nurse, whoever sees this and remembers. This is the second slide I wanted. I don't know where I am now. Sorry. So last case that the baby is discharged 6 weeks and the weight gain is not adequate. So what could be the cause? Had left to right shunt, became symptomatic around the 6 weeks, and thorough evaluation. So that is what, when the baby is not sucking well. This is what, besides the table which talks about, rule out any cause. And we are first taught as student, the first thing whenever we did a cardiac case, we were only taught this, that refusing to feel poor sucking and poor weight gain because the child gets tired. When the DD which we had to tell in exam was this first cardiac cause. And of course, the other causes, this renal, CNS, metabolic, respiratory, the maternal causes of vein, which PPH, pseudoephedrine, depression, hypoplastic. And this is very important and very common, which we call the postpartum blue. I tell my parents, you would have seen that you go to the mother and she starts crying. You feel so upset. Kitni jaldi roti hai. So you need to understand, uske hormones hile hue hain. And I tell the mother-in-law and the dad that because of the pregnancy, her hormones has changed. Her prolactins and all have changed. She gets this depression and she cries easily. Please ensure that you keep her happy, because this is what you would have all seen in your practice, how quickly the mothers cry. Last slide, even the cleft lip, no problem. Keep the baby little higher so that it doesn't get into the nose, aspirate, and use your finger or the breast tissue on the lip to make that part. And you can still feed with the breast milk also, and not necessarily the bottle which we were all taught by our seniors to suggest that bottle to the special bottle to the cleft lip palate. Wrong. This is the way that you need to position, and is applicable to 5 days. The biggest challenge is this, how to sustain after discharge from the hospital. So we must talk about it on the discharge. And I think like the UK people, how there is a lady who goes to the house of the, and talks like the nurse types and all. We are not able to do all that in India. So the responsibility lies a lot more on the doctors and our staff, because we don't have the luxury of teaching. So in your team, if you're able to talk about this to them and your youngsters, and that will be great. Thank you.
Thank you, ma'am. Thank you so
Devendra
much.
ji, मैंने सही किया.
You have done a wonderful job,
Ma'am, wonderful, excellent, ma'am.
Yes.
I speak from my heart, that's sure.
As always.
Now, may
Excellent.
I invite Dr. Upendra Kinjawadkar to speak about the breastfeeding and the COVID-19. Kindly share your screen, sir.
One picture I was supposed to take.
So is it visible and I'm audible?
Yes, sir. You're visible and well audible.
Okay. A very good afternoon, everybody, and best wishes on this breastfeeding week. I thank profusely my dear friend Dr. Devendra Gaba Dr. Alok Bhandari, Dr. Dinesh Goyal, and all the team members of West Delhi IIP for this invitation to participate in World Breastfeeding Week celebrations today. And I was very happy to see two presentations before this. We are based on the nutrition education program which we did in IIP, and I'm extremely passionate and possessive about that module because we started off in 2014 when Dr. Yevle was president, continued it in updated. So that's why that word NEPU came when Dr. Bakul Parekh was president, and when I was joined by Dr. Neelam Mohan, who was the then national coordinator, and she was also equally passionate about the module, and she saw to it that we took this module entire the length and breadth of the country. And I request, I think if you are all sensitized and have liked the first two parts of the module, the entire module is so nice, and sometime later on we can have a complete module for you in Delhi. So friends, with that, let me begin with the first part of my presentation, that is breastfeeding during COVID-19. All of us know that the arrival of a newborn baby is occasion for celebration for parents. While the happiness on arrival of new member in the family is unparalleled, the natural instinct of every new parent is a concern about their baby's health, the milk intake, their everyday growth, progress. So in normal situation, the parents have access to obstetricians, pediatricians for their queries, and they would visit their doctors in a clinic to get answers. But today, in the wake of ongoing global pandemic coronavirus, the social distancing norms, we want them to stay at home, isn't it? So that's why it becomes really difficult for parents to get answers to their questions. Plus, the care and caution to be practiced around the newborn have become a vital concern. So given the volatility of the newly emerging data on COVID-19, there's really uncertainty, but whatever science has shown and told us with affirmation, that I'm going to share with you. So all of us know there is no doubt that breast milk is the best source of nutrition for babies. It protects them from the illnesses. Disruption for any reason, if it happens, there will be a drop in milk supply, refusal by infant, decrease in protective immune factors, and we do not want to happen under any circumstances. Mothers will understandably be worried and asking themselves whether coronavirus can be passed on through breast milk and what they can do to protect themselves and their baby. So it becomes our responsibility to tell them what is scientific. Very reassuring to know that this slide is so important. People without suspected or confirmed COVID-19, those who have not been in close contact with someone who had COVID-19, or those who have received a COVID-19 vaccine, do not need to take any special precaution when feeding or for expressing milk. So very, very important. Out of these first two situations have become common, that patients without any suspected or confirmed COVID or not in contact. But the third part, unfortunately, my own individual practice, I ask every mother, accompanying mother who comes to our clinic, whether have you taken the vaccine? And sorry to say, 90% of these mothers have not taken vaccine. Pregnant mothers have not taken vaccine. I don't know the reason. Still, there is a doubt in their mind that this is not meant for them. So it's our responsibility to see to it that, in fact, government machinery also has to act that our all pregnant ladies and lactating women should take this vaccine. However, a breastfeeding person who is not fully vaccinated against COVID-19 should take precautions. So fully vaccinated is 2 doses of the current vaccines which are available in our country. So they should take these precautions to protect themselves as well as their baby. So because either member of the dyad, if it is suspected, or COVID-19, dyad is a team of 2, that is baby and mama. So now let's say another situation. What if the child is COVID positive? What should the mother do? We know that we recommend breastfeeding at least till 2 years of life. So it is possible that the baby could be COVID positive and mother is not. Because of the risk of danger of suffocation, none of the bodies from UNICEF to our own ICMR to WHO, nobody says they should wear masks less than 2 years. So we as healthcare professionals must counsel the breastfeeding mother on the risk and benefit continuing to feed during the child. So we must still emphasize on the importance of breastfeeding. So this includes that she has to protect herself. So she has to wear a mask during close contact, obviously during the feeding. Otherwise, if it is an older child, 1 year old, 1.5, 2 year old child, they can sleep separately and mother can keep them away the distance more than 6 feet. She has to continue to wash hands frequently before and after touching the child, very important. And pregnant ladies, we know that for at least 42 days following end of pregnancy are at increased risk. So they need to be really very careful. Now, another situation, if the mother has symptoms or has confirmed COVID-19, So what should she do? She should wear a mask or cloth which is covering her face during any contact with the baby, including while feeding. She has to again wash hands with soap and water or use alcohol-based hand rub before touching baby. So this again and again we need to tell them. Sneezing or coughing in a tissue. I had a situation wherein mother was feeding, taking all precautions till 7th day of her illness, and on 8th day something happened and the mask was not worn and she had a big bout of cough and the baby became positive. So this is how even a single mishap can cause it. So this is very important to tell them that continue to wear mask while feeding. Dispose it off immediately and wash hands again. So that tissue paper has to be disposed of. Routinely clean and disinfect surfaces which the mothers have touched. I'll come to surface disinfection again in a while. So one practical point that we need to tell them, that replace medical mask. In fact, I do not stress upon wearing medical mask while feeding. They can use a normal cloth mask, but then if it becomes damp, they should dispose it immediately if the medical mask is worn. And this medical mask should not be reused or touched in front, very important. Whereas a cloth mask can be cleaned and reused. Now, if the mother is too unwell to breastfeed her baby because of COVID-19 or because of its complications, I think it is important to accept the fact that she can express milk, donor human milk, wet nursing are the different options. And the last resort is human formula milk. Today on this breastfeeding day, I don't want to talk about, but then somehow we have to finish, we have to be scientific. As a last resort, infant formula can be given if it is given properly and safely. So now protection from breast milk. See, look at this, what happens. Even if the mother has coronavirus infection shortly before giving birth, she begins breastfeeding, or those who become infected while breastfeeding, she will produce sufficient antibodies, which are protective immune factors in the milk, which will pass on to the baby and will protect the baby, enhance baby's own immune system. So this means that we need to tell them, continue to breastfeed and that is the best way to fight virus, because if you want to protect your baby, you continue to breastfeed. Now, if a mother does fall ill with symptoms, if she is symptomatic, if she was asymptomatic, no problem, then she has to seek medical care early and follow the instructions of the healthcare provider. Now, EBM we talked about as an option if the mother is really unwell. Very important. It is underused in our country somehow or the other, but we must tell them that use only cup and spoon. No to bottle. So expressed breast milk can be given when the mother is too sick to breastfeed. When mothers are too ill to breastfeed, they should seek medical advice for their own concern. But it is possible to express and a non-infected member of the family. It could be a sister, it could be a husband, it could be parents, grandparents, anybody in the family. They can use this cup and spoon and the express milk and they can feed this baby. It will be very important for them also to follow these 3 W's, that is wearing a mask, washing frequently, and washing the surfaces. So at all times to keep the baby healthy and safe is what is the final precaution that we need to take. So how should they go about the EBM? Wash their hands with soap and water for 20 seconds, inspect and assemble. Now we have 2 types of a simple pump or a complicated, sophisticated, you may get on Amazon, Flipkart, there are various kinds of pumps. So basic model is better. Lesser the complication of the intricacies or of the model, it's very easy for the parents to use it. So if the tubing is moldy, discard and replace it immediately, we must tell them. So clean the pump dial, power switch, countertop with disinfectant wipes, especially if it is using a sharp pump. Now for extra germ removal, that needs to be taken care of. Sanitize these parts, even the wash basin and bottle brush, at least once daily after they have been cleaned. Items can be sanitized using steam, boiling water, and now many of our families have dishwasher at home, so they can use that. And this extra precaution is so important, especially for babies who are preterm, who are less than 3 months old, or they have weakened immune system. They have just come out of a sepsis episode or a meningitis, and due to something or some illness or the other, we need to be extra doubly precautious while using this EBM option. Now we as healthcare providers, we have our staff nurses, our receptionists, the staff working in our hospital. They could be having problem. We have to protect them also. They are breastfeeding their baby. How should we do that? We should, now it all depends on where they are working. Now my receptionist is at the most, is actually at the peak of exposure because every patient comes and talks to her. So we need to protect. Whereas somebody working in the lab or somebody who is in doing the accounts part, she doesn't get into contact with so many people. So it all depends on how much is the level of exposure and availability and proper use of PP in your premises. So again, if she has to express breast milk, she has to clean hands before touching the content. But very important, that's what I was talking about, the risk of transfer of COVID-19, SARS-CoV-2 from contaminated surface has also gone down tremendously. So now it is from person to person, not from breast milk, not from contaminated surfaces. However, till the final verdict is out, we need to clean and disinfect the devices, and generally we need to, contamination of surfaces should be taken care of because we don't want to take any chances. Now comes the next choice they have is pasteurization of donor human milk. This is a very good, we know just now we heard Dr. Gaba when he was talking about what are the different options as we go in the options for the babies. So mother's milk is the best. If not possible, then pasteurized donor human milk. But then there was a disruption in human milk donation. All of us have seen that. And remember to important that pasteurization again completely inactivates the SARS-CoV-2 in the donor human milk. It becomes totally safe. So those hospitals which have difficulty in acquiring donor human milk, the available supply should be prioritized. So please, always preterm babies should get the benefit and advantage of this pasteurized donor human milk as compared to a term baby with other problems. Now all of us know NEC now incidence is coming to almost zero. See, that single intervention that exclusively mother's milk, if it is given, then we have absolute almost zero chances of NEC in all these extremely small preterm babies. Now let's come to the final part of it, the isolation and quarantine. This part also needs to be emphasized because additional information, we are the ones who are going to give these mothers how to isolate the period of quarantine also. So for whom it is more important, those living in close quarters or living in shared housings. So breastfeeding person should also follow same rules apply to them also. A child being breastfed by someone with suspected or confirmed COVID-19 is considered to be in close contact. So in fact, they should be told to them. And how much will be the period of duration of isolation for this baby will be the same as much as the duration of isolation and quarantine for that lactating mother. Got it? So very easy. So recommended period will be same as much as the mother has it. So how long the persons of those who are COVID-19 symptoms, if the mother has, and she was directed to care for themselves. So at least 10 days, this remains the same from the symptom onset, and this remains for all the general population also. At least 24 hours should have passed since the resolution of fever without using antipyretic and other symptoms. There should not be any other symptoms. So these 10 days, 24 hours and other symptoms criteria remain same irrespective of whether it is breastfeeding or not breastfeeding person. Now let's see some couple of clinical situations where this can be used. So now I have a mother who is infected with SARS-CoV-2 who never developed COVID-19. So that means husband was positive, she was checked and she was found to be positive. So now, how long she should discontinue isolation and other precautions? 10 days. So for her, because she's totally asymptomatic, accidentally detected as a contact tracing. So she should not, after her first positive RT-PCR, 10 days are good enough. Okay. Now let's see the next. Now, if the same mother who was asymptomatic, if she is severely immunocompromised, the period of isolation goes from 10 to about 20 days. Better to be safe than sorry. So roughly 10 to 14 days is for you and me, Aam Janta. But for these immunocompromised, let's be more cautious and give them isolation of 20 days from the first provision stage. Whether we should ask them to do RT-PCR repeat? No, that remains same. That do RT-PCR testing for detection of SARS-CoV-2 could be considered those who are severely immunocompromised, and our ID expert also feels so that we must do, then only we should. Otherwise, we have seen repeated RT-PCRs even with a dead organism can also become positive. So let's not do that unless the mother is really severe complications following the illness. And finally, the first kind of mother who had no other issues, then for her, there is no need to repeat RT-PCR. A simple isolation of 10 days is what is enough. So when both mother and baby both are COVID positive, that is also possible. So this is also, there is no special precaution. Both of them can be in the same room. Now mother need not in fact wear mask also because they're only mother and child, and if they have an attached washroom, then no problem. So she can continue to breastfeed, she can continue to express milk, and the period of isolation remains same. So that needs to be remembered that if both mother and baby are positive. Now final part is professional support. There are so many mothers, COVID has given so many challenges to us that they who want to breastfeed, but they could not get access to their obstetrician, not to their pediatrician, not to a lactation consultant. So friends, we must try to go one step extra and give them some lactation support, because formula is a very easy solution for you and me to write, but re-establishment of lactation is so satisfying for that mother. So we must make at least a humble attempt to re-establish lactation. And this lactation support, now there are qualified lactation expert, all of us know, every institute has it, because breastfeeding problems we just saw, the cracked nipple, the engorge, the abscess everywhere. So where she requires this lactation support. So this person who is giving, she is going to be very close contact with the mother, so she has to wear proper PPE. So I feel it is better to have alternative sources of approach like a telemedicine. So video consultation has become really a new normal nowadays. So these lactation consultants can very well use it. Mother can very well demonstrate, see to it the privacy is respected of the mother, whatever problem she's sharing with the lactation consultant. And if the lactation consultant has no problem, then she can physically also consult this mother. So this is the way I think we should go about. So friends, to conclude, I would say the reach and impact of this global pandemic we are witnessing is absolutely unprecedented. Optimal breastfeeding practices are now more important than ever. We know that. It is crucial that young parents focus on evidence-based information and not based on WhatsApp University. Decisions taken in these turbulent times should not be under the influence of fake news or misinformation. And for safeguarding the health of newborns, continuing breastfeeding is a scientifically proven measure. Just now, both our first speakers told you about importance of early initiation of breastfeeding. Our exclusive breastfeeding for first 6 months rates have gone up by 15%. They were 58% when we last did it, and now 1920 has shown it has gone to 74%. But sorry to say, the early initiation of breastfeeding in first 1 hour rates have gone down by 5%. So from 57, they have come to 52 or 53%. So it is a shame. So that's why we must focus on that part wherever we attend deliveries. Moment we enter, the moment baby makes an entry into this world, she has to come into immediate uninterrupted skin to skin contact with the mother, and the rest will be perfectly taken care of by the baby itself. So if we do that, I'm sure the breastfeeding rates are going to go up, and our country should have 100% initiation of breastfeeding in first 1 hour and 100% exclusive breastfeeding in first 6 months of life. Thank you very much.
Thank you, sir. Thank you so much. Such a wonderful presentation, very crisp and comprehensive, and very informative. Now, I would like to invite Dr. Richa, our Finance Secretary, to give presentation on post-discharge advices regarding breastfeeding. Dr. Richa, please. Dr. Richa, am I audible?
Yes, sir.
Yes. Dr. Richa, you are not audible.
अनम्यूट कीजिए डॉक्टर रिचा, अनम्यूट कीजिए.
Thank you. Am I audible now?
Yeah.
I want to first of all congratulate everyone on the launch of Breastfeeding Week 2021, and on the behalf of IIT West Delhi. And my talk is on the discharge plan. So we are going to take our talk in two aspects. One is the general discharge plan, and the other is the discharge plan regarding keeping in mind the low birth weight infants and preterms.
Keep your speaker near to your mouth. Yeah, your voice is very low.
Now, am I audible? Am I audible now? Is my voice audible now? Is it better? Is my voice better now?
Yes, it is now better. It is now better.
Yeah. Now this is a mind map showing the general discharge plan that we have to give to the entire family. Now, when a patient is being discharged, especially a neonate, what we have to keep in mind is to give the family the entire counseling. because when they'll discharge the patient, it will be the mother will be requiring the support of the entire family. So the parents, the grandparents, the caregiver, they all should believe in the sustained breastfeeding. So it is very important that while at discharge, we reinforce the continued breastfeeding to the entire family. Now, there are aspects that we have to discuss regarding the mother, the baby, and we can discuss some special issues in the baby, mother, and how we are going to follow up a baby after discharge. So when for the mother, we need to tell that the environment that she will be feeding at home should be stress free, and for that she needs the support of the entire family, and she needs adequate diet, adequate sleep, and also at the time of discharge we need to reinforce the right express this milk collection technique, which I will be taking in detail further. Now, for the baby, we need to reinforce the correct latch position, as ma'am has already ensured the latch score. If it is less than 7, then it is worrisome. So, correct latch position needs to be reinforced. Importance of kangaroo mother care, because it is very important for thermoregulation, and importance of nighttime feeds, because that is a stimulant for prolactin reflex, and what that we should not encourage the prolactinal feeds. Then I will be discussing about special issues like in preterms, how we are going to do the smooth transitioning of the preterm from TPN to exclusive breastfeeding, and what are the problems like if the child is having suboptimal growth, and special issues like cleft palate, tongue tie, special issues which have already been taken up when the mother is sick, like COVID setting, sick mother, mother in ICU, having breast problems, inadequate feeds. And when we are following up at discharge, we have to measure growth parameters as well as biochemical parameters. Growth parameters like adequate weight gain, head circumference, length, and at the same time, we need to stress upon continued breastfeeding and to start complementary feeding at 6 months of age and continue the breastfeeding till 2 years and beyond. And at the same time, reinforce continued sustained family support. Now, global recommendations are for infant and young child feeding are that we should exclusively breastfeed, mother should exclusively breastfeed for 6 months, continue breastfeeding for 2 years and beyond, and we must introduce safe and complementary foods which are adequate at the right age, which is 6 months, and keep on continuing the breastfeed till 2 years and beyond. Now, we should reinsure the hold positions when the mother at the time of discharge. If the whatever position the mother is comfortable in, and we find that the correct latch is being maintained. This could be a cradle position, as we can see, it's a cradle position or a cross cradle, sideline position, or it can be a double. She can feed simultaneously for both the twins while keeping a pillow over here and here. So these can, according to her comfort, we can reinsure that the mother is comfortable in the positions. Then correct latch should be reinsured. This should be actually initiated while the baby is in the hospital, but we should ensure the latch before discharge. And as we can see that these are the criteria. There is a chin is turned towards the breast of the mother. The lower lip is everted and it is completely covering the areola. Then we are not able to see the lower part of the areola, and we will be able to see the swallowing movements also. So audible swallowing is also there, and also lower lip contour is as already told, it's turned towards the mother. So we should ensure a good latch, and mother's whole position should also be comfortable. Now, this is very important, express breast milk technique, because this we will be requiring, we need to teach the mother how to express the breast milk, because this will be required in many situations, especially in cases like prematurity, when there is any inadequate milk secretion, or in case of working mother, or cases where mother is having breast mastitis, breast abscess. So we need to first make a comfortable environment when we are teaching the mother how to express the breast milk. Hygiene needs to be maintained. She should wash her hands, and she can take a pre-warmed katori which has been boiled for 20 minutes in boiling water, wash with soap and water, and then she can keep a wide mouth katori along with her. She may require support of a caregiver in the initial few days. So we have to teach her that first she has to, now this is the breast, first she has to need given continuous massage all throughout the breast. It is like a kneading position. It can be done with the dorsum of the knuckles, or it can be done with the palm. So this is just to stimulate the mammary glands. Then she will make a V. She has to palpate from outer section, and she goes near the areola. First is massaging or all over with the knuckles, like as if you are kneading the dough. Second, she will approximate her fingers towards the areola. Now she has to make a C, like here, where she will be holding the thumb, as well as the holding the breast with the thumb and the index finger. Where the thumb and the index finger, as we can see, is opposing. This is the thumb and the index finger, and this will be near to the areola, where the lactiferous sinuses they open, and she will press her hand towards the chest wall. She will press it towards the chest wall and then release. So there has to be a pressure has to be at the thumb and at the index finger. First backwards towards her own rib cage, towards her own chest wall, and then she will release. So it has to be an alternate release and press, release and press. So this will take a little time, and it might take the mother to express the breast for around 20 minutes, from 20-30 minutes, and from both the breasts. And then she has to keep on circulating this hand all over, so as to have a equal compression from all the lactiferous ducts, and then she can collect the milk in the sterilized container. What is important is that mother should be comfortable. In NICU settings, we allow the mother to come near the baby so as to stimulate the oxytocin reflex. So this will help them in better letdown of the milk. And this express breast milk then can be given to the child. In conditions where the manual breast milk expression technique is not successful, there we can use breast pumps, manual breast pumps, or battery operator electric breast pumps. Electric breast pumps are more successful, and the conditions I've already listed, where there is inadequacy of breastfeeding or problems with the nipple or inadequate suck. And what is help, it benefits in appropriate suction and frequency and long-term use, and it stimulates the hormonal level best, because we are letting the milk being expressed. So we are actually indirectly stimulate the prolactin reflex and the oxytocin reflex. So it will further increase the more production of the milk. So we are allowing the sustained breastfeeding to continue. Now this express milk, we can tell the mother that she can store it at room temperature for about 4 hours, in refrigerator covered with a lid at the back for about 24 hours, and in freezer for up to 3 to 6 months. So preferably, because temperatures out in Delhi are a little higher, this is the temperature like 19 to 26 degrees Celsius, we can keep at 4 to 6 hours. So out here, if it's 28 to 32, around 4 hours, 3 to 4 hours, we can keep at room temperature. And in a refrigerator, it can be kept for 72 hours, for 3 days also. But the important thing is that we must prevent spoilage, and it should be at the back side in the main body of the refrigerator. And in freezer compartment, we can even keep at for 2 weeks, like at -15, and in deep freezers even for 6 to 12 months. So for us, it's more important to stress that you can keep in the refrigerator for about 72 hours also. Now galactogogues have already been covered. They are best is water, and they stimulate the prolactin. Its best galactogogue is prolactin reflex stimulation. So nighttime feeds, they act as a good galactogogue. No to prelacteal feeds, because they are a source of infection, allergy, they interfere with suckling, and they cause nipple confusion as well as difficult state of breastfeeding. So because the baby takes longer time to come to breast. So lactating women diet. Now, if lactating women should consume a healthy, balanced diet, evidence indicates that women are able to produce milk which is sufficient quality and quantity to support and growth and promote the health of the infants. But if we are not giving the mother an adequate diet, then definitely she will lack the nutrients. She will lack the she will get depleted of the stores. So around 2,700 kilocalories per day. At least she should eat 1.5 times of what she was eating before lactation. Now, when we are talking about Post-discharge plan. This is the, now when we are talking about the discharge plan in regards to nutrition of preterm and low birth weight infants, we have to keep certain goals in mind. While dealing with the preterm neonate, our main goal is that we want to bring the neonate gradually to total breastfeeds. So that is our main goal, to have the optimal breastfeeding, that is exclusive breastfeeding. We want that the preterm, that the low birth weight should have adequate weight gain during our journey. We want good neurodevelopmental outcome for the child. And at the same time, since the intrauterine accretion of important nutrients, they are occurring in the third trimester. So usually preterms, they lack the nutrients. So we need to correct the nutritional deficits also in these preterm babies. And since every preterm is at a different level of acceptance of feeds, his competency for oral acceptance is different. So we need to give an individualized plan for each preterm, keeping in mind what is the family's condition, how the mother will be, what will be, whether she's working or she's at home. Now, this slides tell us about how a preterm infant who's like a 28 weeker, this is like 28 weeker, he is gradually showing his transition towards breastfeeding. Now, there are challenges in breastfeeding when we are dealing with preterm. See, what is important is preterm's gut is immature. Second, his sucking mechanisms are not adequately developed. The fluid requirements of a preterm are much more. So it is very challenging when we are talking about feed advice to preterm babies. A 28 weeker, on the extreme right of the slide, a 28 weeker usually does not have a coordination, does not have any sucking reflex, any movements also. So we will start on total parental nutrition at day 1. As the child is growing and moving towards 28 to 31 weeks, then we may start some minimal enteral feeds. And these can be given through oral gastric tubes at the rate of 20 to 30 ml per kg per day. And at the same time, we have to keep on transitioning. We can try spoon feeds at 33 to 34 weeks. Now, a child who is like 32 to 33 weekers, we should rather initiate non-nutritive sucking. So we need to put the neonate at the age of around 32, where he is mature enough to develop some suck-swallow coordinations. We should practice non-nutritive sucking. So we need to put such neonates to breast, and so as to give them practice for sucking and to increase the KMC and the maternal bond and for better milk letdown. So at the age of 32 to 34 weeks, if the baby is stable, we can practice non-nutritive sucking. If the baby is not stable, then definitely we need to continue with IV fluids. And we can start with pellet feeding also. So pellet feeding will be, a spoon feeding will be on reaching the full enteral feeds. And after 34 weeks, once the sucking reflexes have matured, we can try complete breastfeeding, and we can monitor the other parameters, tolerance, blood sugars. And so this is a time where we are happy that the child might now obtains optimal breastfeeding. That is, he is towards gaining on full breast. Now, this is the practice of supplemental sucking technique. Supplemental sucking technique, as we can see here, that here the mother's breast is being attached, a tube is being attached at the mother's breast. So the baby is sucking milk from the breast, and the milk is coming from the tube, and it appears as to him as if it is coming directly from the breast. So this is supplemental sucking technique. It is very useful and very helpful, and it should be practiced maintaining all the hygiene of the tube. So for babies with weak suck, for preterms, for slow feeders, where we need additional stimulation to mothers who are suffering from low milk supply, this is a very good technique. A mix of so many techniques is being practiced when the child is being discharged. We can give him on exclusive breastfeeding plus EBM plus feeding with a supplemental sucking technique. So it is better than giving any day better than giving any nipple, because it will avoid the nipple confusion. It will have all the benefits of KMC, and it will encourage the oromotor control of the child. So it will have a stronger suck, and it will and good oromotor suck swallow mechanism. Now, these are the parameters which we need to see before discharging a preterm. Now, when we are discharging a low birth weight, a preterm, we have to ensure few parameters. First is that there should be a sustained weight gain in NICU for at least 3 days before discharge. The child should have attained physiological stability so that he can maintain a normal body temperature. And he should have become a competent oral feeder, be it from cup, paladay, or breastfeeds, but he should have attained some competent oral feeding mechanism. And we are sure that the mother and the family have attained enough confidence that they can feed the baby at home. The child has attained sufficient respiratory maturity, and we should ensure that they come for the regular follow-up at least weekly to us. Now, this is which growth charts we have to use in case of preterm. So we need to monitor the weight, length, head circumference to know what is the catch-up growth, and initial postnatal weight loss is expected in the first week of postnatal age group. Now we have different charts that we can use for preterms. We have charts like intrauterine growth charts, Osland growth charts, or we have charts which are post-menstrual age growth charts, that is postnatal age growth charts, which are preferable because they are they are more realistic. So we have two charts. One are the Fenton growth charts, and the other are intergrowth charts. These are the Fenton growth charts for boys and girls, and these are the international intergrowth charts which can be used. And we plot a child's growth up till 50 weeks of gestation. After that, we can use, after 52 weeks of gestation, we can even use the WHO growth charts. So here we have a scenario where we have a preterm. We have a scenario where we have a extremely low birth weight baby who was born at 710 grams, and in nursery, in NICU, he has showed sustained weight gain, and he was discharged at 33 weeks, that is at around 1.3 kgs. But when he went home and came back to us at after 4 weeks, the post-discharge weight was 1.2 kilograms, that is 1300 grams, and he went below, he became 1200 grams. So instead of weight gain, which should be at least approximately 15 to 20 grams per kg per day, it was it was a loss of 100 grams. So what could be the possibility in this case? What we should ensure when such a neonate is brought back to us during our follow-up visits, and what corrective steps we can take in such situation, and how are we monitor the baby subsequently. So what could be the reasons? We have to reinsure whether there is inadequate feeding due to poor suck and swallow, whether the mother is having inadequate breast milk, or the baby is losing calories because the baby needs to fight the cold stress, and whether the baby is having problems like exaggerated anemia of prematurity on which we have forgot to act on, or whether there was inadequate calorie and protein intake because of lack of fortification or discontinuation of fortification, or the baby is sick because the baby has had sepsis or electrolyte imbalances. So this needs to be reassured. We need to again take the history that how the mother is feeding, whether she is feeding by breast or by expressed breast milk, how the frequency of urination is there, is it at least 5 to 6 times a day, how the baby is sleeping, whether he is sleeping 5 to 6 hours a day, is comfortable, and are there any signs of sickness like vomiting, breathing difficulty, and whether the mother is giving supplements or not. Now, this is the chart which tells us regarding the biochemical parameters for premature infants in the post-discharge period. Now, when we are monitoring a child in our OPD for the follow-up weight gain and follow-up growth, we need to see the weight gain, which should be at least 20 grams per day. We need to act if it is less than 15 grams per day. We have to monitor the length increase, the head circumference increase, which is usually 0.5 to 0.8 centimeters per week. But if it is less than 0.5 centimeters per week, then we need to act. And weight for length, it should be greater than 85%. There are few biochemical parameters also which we can monitor. One is the hemoglobin. Hemoglobin should be kept above 11.5 grams per deciliter. If it is below 11, we need to definitely act. Then vitamin D levels should be above 30 nanograms per ml. Phosphorus should be above 5 milligrams per ml, and alkaline phosphatase should be less than 450. If it is greater than 500, we need to add. And blood urea nitrogen. Now, how we are going to address the feeding issues in a preterm? So, in a preterm or low birth weight, the minimum fluid intake can be from 150 ml per kg per day. It ranges from about 100 ml per kg per day to maximum about 180 ml per kg per day. So, like for a 1 kg child, we are going to have 15 ml feeds. So, there will be 10 feeds. So, we again have to reinsure the family circumstances. Are there any reasons for stress in the mother? Has the caregiver changed? What was the correct techniques? And are they practicing non-nutritive sucking? And what are they giving? Now, a comment on the use of human milk fortifiers. Human milk fortifiers are used especially for low birth weight infants and for infants, preterm infants, especially those who are less than 1500 grams or less than 32 weeks gestation. This is because we need to increase the nutrient, we need to actually bridge the gap of the nutrient deficit in the preterm. So for that, a proper training of mother is required for use of HMFs. So we need to first estimate approximately the milk intake and calculate the dose of HMF. In the express breast milk, we will be dissolving the HMF. We ask the mother to wash her hands to maintain sterility, and then mix around 1 gram of HMF sachet in 25 ml of express breast milk. We have express breast milk of different companies. There are total human milk fortifiers which are actually from human milk only, and there are human milk fortifiers of bovine origin. So there is no need of fortification with MCT oil, which is not recommended, and special post-discharge formula are not available. Um, Now this shows how the preterm milk has got a deficit. There's a deficit in the preterm milk of protein, calcium, phosphorus, zinc. Protein is 1.5 to 2 grams per 100 ml, and there is a deficit of around 1 to 2 grams per ml. Calcium, again, there is a deficit from 20, and the requirement is 120. So there's a deficit of 80 to 120. And so this is showing a deficit of almost all the important minerals and zinc and vitamins. So they need to be supplemented, and one way is human milk fortifier. So the preterms, they require a post-discharge nutritional supplementation. As we all know that the intrauterine accretion of nutrients occurs in the last trimester, so preterm, they require this nutritional supplementation. So we need to give multivitamin with zinc. It can be continued up till 1 year. Calcium is to phosphorus. We need to continue in a low birth weight till the neonate reaches a weight of 3 kgs. And vitamin D, 800 IU per day. According to ISPGAN guidelines 2010, we have to continue till 1 year. According to American Academy of Pediatrics, we can give 400 IU per day. And iron supplementation needs to be started at 4 to 6 weeks. We start an iron supplementation in a preterm or low birth weight at 4 to 6 weeks, and we can continue even till 1 year. Whenever we are calculating the dose of multivitamin, we have to calculate according to the vitamin A requirements. So vitamin A requirement is 1500 IU per day. So the dose is to be calculated according to the vitamin A. Zinc requirement is 2.5 to 3 milligram per day. And vitamin D can be 800 to 1000 IU per day according to ISPGAN, depending upon the age of gestation. And calcium is 150 mg per kg, and phosphorus is half of it, that is 75 mg per kg. So our discharge plan needs to incorporate all these things: a vitamin A supplement, a vitamin D, calcium. So we have this slide shows that we have different brands of multivitamins available. So we have brands which have got 1000 IU of vitamin A, 3000 or 6000. So our ml will then keep on changing depending upon the amount of vitamin A that we have. A brand C which has 1000 IU, we will give 1 ml. A brand C which has got B which has got 3000, we can give 0.5 ml. So that can be adjusted. The point is that we need to see the dose of vitamin A. And again, there are brands which are having different amount of vitamin D. Some having 250 IU of vitamin D, some 400, some 800. And then C also is different, 40, 40, 80, and so on and so forth. Now, this is the brands of calcium. The calcium also we get in different concentrations of elemental calcium. We have brands having 250 milligram of elemental calcium, some having 150 milligram of elemental calcium, and others having 82 milligram elemental calcium. And so we will calculate according to the concentration of calcium, and the dose can be calculated as already told, 150 to 150 milligram per kg per day. Now, this is the slide which is showing what is the iron supplementation at different weeks of gestation. So, iron supplementation, when we are dealing with a preterm who is less than 1000 grams, it is to be 4 milligram per kg per day, and 4 milligram per kg per day. Then we are dealing with 1000 to 1500, then it is 3 to 4 mg per kg per day. In 1500 to 1800, it is 2 to 3 mg per kg per day. And for a neonate above 1800, it is 2 mg per kg per day. And we can start at 4 to 6, continue till 1 year. For babies who are less than 1500, we can even start earlier, not 4 weeks, we can even start at 2 weeks. Are again showing the different brands of iron, showing having different concentrations, and we can calculate the ml accordingly, 10 mg, 20 mg, 25 mg. Now we need to, at the time of discharge, also we need to reinsure that the mother should maintain a KMC of around 8 to 10 hours. She can defer bath till the baby reaches 2 kg, and we can teach her wrapping and clothing techniques. And oil massage may be advised twice a day. So what will be the frequency of follow-up in preterms? What should be the frequency of follow-up? For growth monitoring, we need to initially, if we have discharged, we need to bring the ask the child to come within 72 hours of discharge, and then we can call the child every week till a period of 1 month. So initially 2 to 3 days, then every week for a period of 1 month, and then every month for a period of 6 months corrected age. So, and then every 2 months for a period of 1 year. So initially the follow-up is weekly till a period of 1 month. And biochemical monitoring may be done first during the stay in the hospital, second at 1 month of discharge, and third at 4th month of corrected age. So important again is to stress upon the complementary food, which should be started at about a corrected age of 4 to 6 months for preterm infants. Currently, most babies will be around 5 kgs. They would have had some neck support, and tongue thrust would have eaten. So, complementary foods, they can be chosen for the preterm as per the recommendation for term infants. They should be started at 6 months of age. Now, there can be long-term metabolic consequences of overnutrition. If we are not giving, if we are replacing the human milk fortifier overtly, or we are using excessive use of preterm formulas, then enriched formulas, then this can lead to accelerated growth in infants. So this can lead to a metabolic syndrome. If there is a very fast catch-up growth of these overweight infants, it can lead to problems like obesity, diabetes, cardiovascular disorders, hypertension later on. So we need to strike a balance in what we are striving. As far as possible, exclusive breastfeeding is the answer, and if we know that the baby is gaining weight on exclusive breastfeeding, this is not something.
Ribdaman, kindly mute.
So our goal is healthy catch-up growth, prevention of nutrition deficiencies, and avoidance of avoidance of obesity. That should be our goal. Breastfeeding Breast milk, in terms of quantity and duration, has shown a considerable benefits in mortality, in morbidity, in developing of good cognitive function, and prevention and reducing the risk of metabolic syndrome in low birth weight infants. So it is the answer to all our problems. Hence, every effort should be made to provide maximum breast milk to low birth weight infants from birth through the first 2 years of life. I've almost covered everything, but just to summarize at the end of this lengthy talk, few points which I've covered. One is it is essential to sustain optimal growth in NICU graduates after discharge. All efforts should be made to sustain lactation. Adequacy of milk intake, fortification, thermoregulation, supplementation, kangaroo mother care, it ensures adequate postnatal growth. And growth monitoring for catch-up growth should be done on appropriate charts. Proper vitamin and mineral supplementation includes iron and vitamins, calcium, phosphorus. It should be followed. Complementary feeding should be started at 4 to 6 months corrected age, and implications of fast catch-up growth being recognized, and hence nutrition strategies may have to be redefined in the future. Thank you.
Thank you, Dr. Richa. Such a very informative and comprehensive presentation by you.
Thank you.
Now we are ending at the end of this program. It is a wonderful CME, and I would like to put my vote of thanks. First of all, I am thankful to my whole executive board and our president, Dr. Alok Bhandari, and President-elect Dr. Devinder Gaba sir, Finance Secretary Dr. Richa, and our whole each and every EB members who has supported us and who has formed this program. Then our national faculty, Dr. Neelam Mohan, she has presented a very well, very informative talk, and she has rightly pointed out the question. BFHI is only up to the hospital, that is for 2 to 3 days or 4 days. But what is after that? Can we start a BFHI, breastfeeding hospital initiative to breastfeeding home initiative? So my worry is that we can have some breastfeeding follow-up visits for the discharged newborns in the after 1 week of discharge, or after 1 month of discharge, or at the age of 3 months of the baby. Then we can assure the breastfeeding it smoothly going on or not. Then Dr. Upender has done a wonderful job, and he has pointed out in this last 1.5 year of this COVID pandemic, when the family members has suffered COVID, mother has suffered COVID, or she has delivered or a baby, the how to go for breastfeeding, whether she will directly breastfeed the baby, or family members can breastfeed the baby, or a family member can feed the baby by taking express breastfeeding. So he has done a wonderful job, and he has shown a path to us how a COVID positive mother or a COVID positive family members can allow breastfeeding and after delivery. Then Dr. Richa has done a wonderful job also, and she has rightly pointed out what should be done in the post discharge, and how to monitor these babies, how to supplement breastfeeding, how to improve the latching and all those. And I don't have words to say how the Dr. Gaba has started this whole event, and he has done exact job, excellent job. He how to latch, what the difficulties in latching and attachment, and the how to promote the breastfeeding in your hospital settings, and how can we help out the mothers. So it's a wonderful complete event from basics to the all till discharge of the baby. So, and I would like to thank the audience, the listeners, especially Dr. Uttam Pal and Dr. Wankhede is there, Pramod Wankhede is there, and Dr. Sangeeta, Dr. Suchitra, and I think it's not possible to take each one names, but nowadays in this you can say the digital world where the CME online program is going at a very, very, high numbers, and to spare time for a event is very difficult. So मुझे लगता है कि before speakers I should thank to the audience who has attended this program, sparing the time and giving opportunity to us to present our topics in front of them. On the behalf of IAP West Delhi City branch, I am very, very thankful and my sincere gratitude to all of you who has done a wonderful, justice, right justice to this breastfeeding module. Thank you so much. Now, I would like to take some comments from few members. Dr. Uttampal sir, you want to say something?
Thanks to all the speakers, they have been very nice and they have elaborated the topic very nicely, concisely.
Thank you, sir. Dr. Gaba, sir.
All to be there
yes.
on physically on 3rd.
Yes.
On
yes.
At Sishu
Yes. 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 Dr. Gaba, sir, your comment, sir.
Yeah. I'm also thankful to all the speakers, Dr. Upendra, Dr. Neelam Mohan, Dr. Richa, the wonderful covering of the topics. And I think breastfeed week has started with a, you can say, boom from West Delhi. Yeah.
Yes.
Yes, sir.
And Dr. Alok Bhandari and Dr. Dinesh has done a wonderful job by helping start this week with the Zoom meeting on breastfeeding. Thank you, audience. Thank you, Dr. Uttampal. Thank you, everyone.
May I know Dr. Smita Mishra is with us also. She is a very senior member, past secretary of Delhi IAP. Ma'am, you want to say something?
Thank you very much, Dinesh, for giving me this time. And congratulations, IAP Delhi West, for this wonderful program. Dr. Alok Bhandari, Dr. Dinesh, Dr. Richa, Dr. Gaba. But I was really interested into this because I am a pediatric cardiologist, and Dr. Neela Mohan really gave a particular part of her speech to the cardiac patients. So breastfeeding in cardiac patient is really difficult. So many times expressed breast milk remains only the option. So thank you very much for covering that aspect from my side. Thank you so much. Yeah.
This year the theme is protecting breastfeeding. Where lies the responsibility? So where lies the responsibility from doctor, patient, and the family? The whole three have the responsibilities. We have to protect this breastfeeding to sustain growth in extra-uterine period. Thank you so much. Dr. Puneet is also with us. He is the editor of the branch. Dr. Puneet, you want to say a few words? I think he's left. Dr. Puneet?
Unmute yourself, Dr. Puneet.
Dr. Puneet?
Unmute kar lo.
Yes.
Hello.
You want to say some, sir?
Yes, sir. It was a good session. As we all know, the responsibility lies with all of us.
Yes.
From doctor to mother and the whole family.
Whole family.
You know, mother needs a lot of support.
Yes.
So responsibilities of all of us to promote, protect breastfeeding.
That's good. Thank you, sir. Thank you so much. I think now we should end this program. Thank you, sir.
Thank you, sir.
End kar de, sir.
Thank you, sir.
Should I end this program now?
Yes, sir.
Thank you again, everyone. Thank you. Thank you so much.
Welcome, sir. Welcome.